As two practicing physician assistants, we've seen a lot and we've heard a lot. We know that you've heard a lot too. We are here to help you navigate through the BS by having open and honest conversations with other practicing professionals. I'm Heidi.
And I'm Cassie, and welcome to Mindfully Woman.
Okay, welcome back to another great episode of Mindfully Woman. We have an amazing episode for you guys today and a wonderful special guest, a dear friend of ours, Cassie and ours, and a wonderful colleague and mentor. She is a breast surgical oncologist, and her name is Dr. Erica Giblin. Welcome.
Thank you. Happy to be here.
Yes, we're excited to have you. To start things off, we're going to have you tell our audience a little bit about yourself and kind of your journey to becoming a breast surgeon and why.
Sure. So I'm originally from the East Coast, grew up in New York State. And originally, I never thought about becoming a doctor. I was actually going to be a racehorse veterinarian. Yeah. Never thought about human medicine. So
Really?
It wasn't until high school. I was doing a research project at Cornell University, which has a vet college. And I had my hand up a cow's butt to feel something. I can't remember what. I thought, I'm not going to do this. So I went home, told my mom, research is great, but I think I'm going to pivot to human medicine. So my mom, gotta love mothers, she says, go volunteer in a hospital, make sure. So I went into a hospital, volunteer, and they actually put me in the operating room randomly. And when I was there the very first day, I was an orderly, like pushing patients around. Yeah. The orderlies came up to me and they said, do you want to watch a cool case? And I was like, sure. So they put me in a heart room where they were doing open heart surgery and doing a valve replacement and bypass. And I loved it. And when I got done watching the case, I went up to the thoracic surgeon and said, I want to do what you do. And he burst out laughing and said, nuh-uh. And I said,
are you kidding me?
I was like, why not? And he's like, you're a female. You can't do it.
No.
So I went home, told my mom that day I'm going to go to medical school. So
wow.
Went to
Good
medical school.
Yep.
Got through that. Loved surgery.
Yeah.
Loved everything about it. I mean, you can cut the human body. It heals. They do better than they were. I thought that's almost miraculous.
Yeah.
So then I went on to do surgery training. Really loved cancer. The idea of getting it out of there, just really helping the person. So I really liked breast cancer because the technology keeps eclipsing all other cancer sites. I mean, they just keep coming up with new things to really just help us get to that final thing, which is cure for everybody, not just some people, but everybody.
Yeah.
It's
amazing.
That's
quite a journey.
Yeah.
To get where you are now. Oh, I love it.
Wise Mama Giblin.
Yes, she is.
Now and back then.
She's like a true North Star.
Yeah, really though.
Are you glad you chose breast surgery?
Without a doubt. I like what I do. I like the patients. I am always amazed and interested on how the technology moves forward. Because without things moving forward, you're stuck where you're at in terms of anything, any medical care. But when you see things getting better and improving survival, improving cosmesis, it really makes every year interesting because you don't know what's around the corner.
Yeah.
Yeah.
Major breakthrough any day, so that's exciting.
Do you feel like breast surpasses other cancers in that way?
Everything. Lung tries to follow it. Colorectal's trying to follow it. Breast is leading the way in every avenue of research.
Okay.
Which is amazing. Yeah. And I know we talk all the time about it, but you're always like up to date on like the newest research and studies and things you can do to help your patients better too, which is
you have to
amazing.
You want to be able to offer those things as soon as they hit the market.
Yeah. Absolutely.
Yeah.
Why do you think breast is in the forefront? Just because so many women
are
are
diagnosed? I think a couple
diagnosed?
things. I think Komen, when they came out with the Komen Foundation, and when they really started to market that. So before that stuff happened, women wouldn't talk about breast cancer I mean, at all. They would hide it. You know what I mean? They wouldn't go to the doctor because it was shameful, right?
Right.
The breasts are involved in sexuality, who we are as a human, as a female. So a lot of women would basically show up when it's sort of too late. You know what I mean? That's cancer's gone too far. It's too big. But I think once people like the Komen Foundation humanized it, and then it became something that was easily talked about. The NFL wears pink now. Do you know what I mean?
Really
now it's all over the place. Wearing pink was signified breast cancer research and cure. I think those things really made it push forward. And then you have the passionate patients behind it. With all the advances, think about the not hundreds of thousands, millions of women that were in research trials to help us get to where we are today and who still continue to go into research trials.
Yeah.
I think all of that and the amount of women who are willing to help push it forward as patients, I think that's the driving force.
Mhm.
Yeah.
So, yeah.
Yeah.
You're as big as your team, right?
Definitely.
Yeah.
And that's so motivational too, for everybody knows somebody with breast cancer.
Yes.
And so then it hits home. So if you
Mhm.
can have people who are willing to put themselves out there, makes a big difference.
Mhm.
And obviously in treatment to come
Absolutely.
for
One
the
person
future.
can help the future.
Exactly.
Yeah, absolutely.
Yeah.
Yeah.
So of course we know you see breast cancer patients,
Yep.
but tell us a little bit about like what you do day to day. Like what kind of people do you see? What kind of patients do you treat and
Yeah.
take care of?
Yep. So we see breast cancer and we see benign breast lesions. So cancer is cancer, which we'll get to in a minute. But like if people come in with bumps and lumps and they don't know what they are, what's going on, do they have to have them cut out? Do they not? We help make sense of all of that. And we help them go through the imaging. If they need a biopsy, do they need a surgical biopsy? If so, why? So a lot of those lumps and bumps, we just try to clarify for the patient what they are. Do those increase their risk of breast cancer? Do they not? So that's the mainstay of what we see. And then we'll see other things like people come in with breast pain, or they might have little changes on the skin of the breast, things like that.
Awesome.
Yeah.
Mm-hmm.
Segueing into that, like seeing people for all these different things, when they come to see you, they probably have some type of imaging done already. Can you talk a little bit about mammograms and like what truly is a mammogram and what type of imaging do you see people have done before they come and see you?
Yep. So part of it depends on the age group. Okay. So if somebody's coming in super young, like yesterday I saw a kid essentially, a 16-year-old kid with a lump. They'll come in with an ultrasound, okay? Because of their age, their tissue is going to be super thick. It'd be real hard for a mammogram to even see anything because a mammogram's an x-ray. So they'll get an ultrasound, which is sound waves, okay? And that can help us figure out what's going on. For people who are like in their mid-late 30s, 40s, 50s, and older, mammogram is pretty much the first thing those people are going to get. And a mammogram's an x-ray. That's all it is. You get an x-ray. But the way they do the x-ray is super fun. They smush your breast in 2 different ways to take that picture. Because you think about it like a ball. You got to get the ball to be a pancake. So you can actually see through that as easy and as accurately as possible. But it's literally x-rays. I think a lot of people think it's a ton of x-rays. It's actually a super low dose. You're going to get 7 to 10 times the amount of radiation just flying from here over to Europe as compared to getting one mammogram. So the radiation is negligible.
Yeah.
People go in the emergency room all the time and they get CAT scans of the abdomen. And like if you get 13 CAT scans of the abdomen, your risk of cancer increases. You'd have to get a ton of mammograms, several hundred, before you can hit that radiation dose. So I think a lot of people are scared of radiation with a mammogram when actually they shouldn't be, because just going outside and flying on an airplane is actually more at risk to you in terms of radiation exposure. And they don't know that.
Yeah.
That's a great point, because I feel like a lot of people ask me that too. Like, how much radiation exposure am I getting from just this mammogram alone? And it's very, very minute in the whole.
Negligible compared to everyday activities people do every year. People go on vacations every year. The sun coming through the window of the car is radiation.
Yeah. It's like we need those mammograms to detect breast cancer.
Absolutely. So, mammogram is the mainstay. So that is a screening tool. So that means for population health, United States, other countries, the world, it is the cheapest, most accurate means to basically evaluate the breast. When there are things seen on the mammogram or the patient's feeling something different, that's when we start to go to other avenues of imaging in addition to mammogram, which includes what I just mentioned before, which is ultrasound, sound waves. Sometimes we use a modality called breast MRI. So breast MRI is literally a magnet that's inside of a tube and it's taking a picture. And we tell patients when we do the MRI, we're looking for hotspots. But what a hotspot actually is blood flow. So a lot of people think, oh, are you seeing a mass on an MRI? We're not seeing that. If tissue's active or if it's cancer, it makes blood vessels grow out of it. So then you got a ton of blood flow going through that thing so the picture is able to see it. So, yeah.
That's super interesting.
Yeah.
Have you seen a lot of progression too, like over your career in the change of like mammograms from where they were to where they are now?
Oh, absolutely. Yeah. So mammograms back in the day were film.
Yeah.
Like you take a picture, you put it on a light
like
board.
the light board X-ray.
I was trained during that, so I'm not that old. So anyway, you'd hang that up on the board and you squint and you look at it, try to figure out what's going on. Then it went digital. Okay, so that improved the quality of what you're able to see. And now we have 3D mammograms. The fancy name is tomosynthesis. But it's still x-rays. It's just that the x-rays go in an arc over the breast. So it gives you an additional 50 to 75 images. So it's like, in a way, they'll say a mini CAT scan, but it's not a CAT scan.
Yeah.
It's x-rays. It's just it's slices of x-rays, which helps with the accuracy. That is standard of care nowadays.
Yeah, that's fantastic. And so for an average woman, how often should she be getting a mammogram?
So there was a lot of debate on this. My mom even asked me today. She goes, should I be getting my mammogram every 3 years? And
Every 3 years?
Yeah, right. So public, calling out mom. But I was like, where did that one come from?
Yeah.
So to just go through the debate really quickly. So about 10 years ago or so, the United States Preventative Task Force, sort of big governing body for the U.S., said that if you're age 50 and above, you can determine if you want to get it every 2 years. And in fact, I think they actually amended it to age 40 and above. You can get it every 2 years. And then after age 70, they said you can stop it. But there's a little paragraph below it nobody read, which was if you were in very poor health at age 70, like you weren't expected to live like 5 more years, then you stop the mammograms, right?
Yeah.
But we all know 7-year-olds who are like going to live to 100.
Yeah.
Yes.
Those people should still get mammograms. But anyway, you had that all going on, and people got confused, and they didn't know if they could get their mammogram every 2 years. Then people started to forget, and 2 years became 3 years, like what my mom just said today. Right? So it's easy to slip. The years go by, right? You can't remember if it was 2 or 1.
Yeah.
Yeah.
The other thing that they started noticing is something called interval cancers. Okay. So what that is a cancer developing between the time you get your mammogram and your next one. Okay. So what they found was if you're spacing them out, you had more cancers developing in between those times. So that's why now everybody's saying go back to yearly on that one.
I see.
That makes sense.
Yeah.
Yeah. Yeah, there's been so much like taboo information out there, like to every 2 years,
It's very-
every 1 year.
Super
Yeah.
confusing.
And I think it too depends on like your specialty. Because if you're working in like family medicine, you go off the USPSTF like guidelines and it says that, and it can be confusing. So
Yeah.
it's good to
Even the
clarify.
specialties like American College of Radiology, American College of Breast Surgeons, they have different guidelines.
Yeah.
You know what I mean? Like someone
Yeah.
say at age 45, you start yearly. It's age 40, age 50. I mean, it's no surprise the public is confused as heck. The
Right.
doctors were.
Right.
Yeah.
The doctors are.
It's
So
true. Yeah.
A lot of reeling it in and getting
Yeah.
people on the same page.
Absolutely. So what are your thoughts on some other imaging modalities like thermography? Oops, sorry, now I can't say it.
Thermography,
Yeah.
so thermograms.
Yeah.
So the idea of them is really good. So what it's basically doing is you're taking a body picture and you're looking for areas where there's more heat signature. Well, all that means is you're looking at areas that have more blood flow going on. So remember we just talked about the MRI, or looking for blood flow, but the MRI looks at it in a different way, okay? It's looking at how quickly the blood goes in and goes out of that pooled area. Thermography is just looking to see is there more heat coming off. The idea is good, but the thing is different things make heat. Cancer can, inflammation can.
Right.
So it's hard to tell the difference between the two. And thermography, to see the heat, you have to have detectors, right? Like for anything, you need a detector. On average, thermography detectors can only see down to somewhere between 1 to 2 centimeters. To put it another way, a mammogram can see 3 millimeters of calcifications, which could be stage 0 breast cancer.
Yeah.
And even a PET scan's better than that. It can see 8 millimeters of disease, whereas a thermogram may not even see that.
Yeah.
Okay.
Yeah.
So the idea is good. The technology needs to get better. It's
Yeah.
not there.
Wow, 1 centimeter to 2 centimeters. I mean, that's
We're starting to go to
that's
stage 2.
large.
Exactly. Like you're progressing at that point.
Yeah.
Yeah.
So
and for the small-breasted women, that's
yeah.
big.
Well, not only that, let's just say part of the people listening are like, I want to do thermograms no matter what. But here's the thing. If it comes back with an abnormality, we can't biopsy a thermogram. There's no technology to say, that's the spot. Let's hit it with a needle. We know we hit it. You have to do a mammogram and an ultrasound anyway.
So you
if they
can't
see
get
something
around
abnormal.
it.
So you're robbing Paul to pay Peter.
Yeah.
Yeah.
Got to do it anyway.
Exactly.
Yeah.
I feel like that's kind of similar. I don't know if I found something recently. It was like a QT scan.
Okay.
And it was like an ultrasound, like a very high tech ultrasound, but basically like a bath. You like sit on a table and you put your breast in water, and then it's like a super high frequency 3-way ultrasound.
Yep.
And the more I was reading on it, it was the same situation. Like I think they can only detect about 1 centimeter, and then same thing. You still have to go through like the mammogram workup and everything too.
Yep. So if somebody has if somebody is screening for like family history, like they have an increased risk of breast cancer or very dense breast tissue, like the mammogram's hard for it to see. They've compared ultrasound to MRI.
Yeah.
Okay. They've done multiple studies looking at that. MRI blows ultrasound out of the water every single time. So for 1,000 women screened, an MRI is able to detect 15 to 50 breast cancers that the mammogram can't see.
Mhm.
Ultrasound can only detect 3 to 4 per 1,000 screened that the mammogram can't see. The numbers are
Yikes.
unbelievably
Yeah.
different.
Significant.
In the research. Yeah.
Yeah, that's
Wow.
significant.
Are there
Okay.
like for thermograms and these alternate modalities? I
Mhm.
mean, I feel like they'd be scarcely provided, right? Like, are they like at like bigger institutions, like maybe like a research hospital?
A research hospital may be using them to just basically try to figure out the detectors, because that's where
yeah.
it's coming down to, is how do you get the detector good enough to detect a smaller object,
Yeah.
a smaller lesion. But outside of that, where I'm seeing it mostly marketed and utilized is perhaps in functional medicine. No slander against them.
Mhm.
It's just, once again, I think it can be a tool that's helpful, but it should not be the mainstay of surveillance.
Mhm.
When you're going to go get a picture to screen for cancer, to me, it just logically makes sense. You want the best thing to screen accurately to find your
Yeah.
cancer.
Yeah.
You don't want a 50-50 split on
Right.
is it going to work or not.
And
I
Exactly.
wouldn't
the
bother to
very
show up.
small, the smallest it could possibly
Yeah,
be,
this
and
is
be
cancer,
able to
man.
see.
Cancer doesn't fool around.
Exactly.
Even
Yeah.
small cancers can be unpredictable. Some of
Right.
them are small, but man, they're mighty and they move fast.
Mhm.
So you just want to try to find it as fast as possible.
Yeah.
Mhm.
Yeah, absolutely.
On that note, how often, like, what do you know a percentage off your head that cancer is caught on mammogram? Since most
Mhm.
women are doing screening mammograms.
Yeah, so with the 3D, the tomosynthesis,
Yeah.
the newer mammograms, cancer accuracy in terms of detection, finding it's really there, is
Mhm.
about somewhere between 80 to 87%.
Okay.
So it's not bad,
That's
Yeah.
not bad.
in terms of screening mass populations.
Yes.
Mhm.
A lot of people.
That is
Yeah.
a lot of people.
Yeah.
Yeah, that's pretty good.
But to that effect, right, 80%, we're missing 20%. So
Mhm.
we'll do
Yeah.
glasses half empty on this, right? So that's where it's helpful for us to know if certain people need additional imaging because their risk is higher of getting breast
Mhm.
cancer over their lifetime.
Mhm.
So that's where things like family history come into being super important. And not just breast cancer, all cancers. And a lot of people come into my office and they'll be like, well, my mom's side didn't have any breast cancer. I'm like, well, what about your dad's side?
Yeah.
And they're like, why does that matter? And I'm like, because you get your DNA, half of it's from mom, half of it's from dad.
Yeah.
Dad's side of the family matters just as much. And a lot of people don't know that.
Yeah.
So that's a big thing, because if they got cancer popping all over, they might be somebody where that 20% is a bigger deal. You know what I mean? And we
Mhm.
should do additional imaging like breast MRI, as I mentioned. Or if they have super thick gland tissue. So you have something called breast density. All women now who are getting mammograms by law are going to get a letter saying if their tissue is dense.
Mhm.
I just saw a patient 30 minutes ago that thought breast density was based on the size of her boobs.
Mm.
Has zero to do with it. It doesn't matter if
Yeah.
the boobs are big, small, ginormous. It doesn't matter.
Yeah.
It matters how they develop during puberty. So some people during puberty, they just have a ton of fat in the breast, very little gland. The gland's the stuff that feeds baby milk, right? So they don't have much of that. So their mammogram's super easy breezy to read. Some people got a ton of those milk ducts that feed the baby milk, a lot of gland tissue, and the mammogram, you can't see anything. It's so thick. So some of those people might need additional imaging.
Mhm.
Mhm.
Yeah. With that, do you, like, if you see somebody who needs something done, can you walk through maybe what types of biopsies there are out there and like how to go about that? Like if you see something concerning on an MRI, like does that necessarily mean you need to do an MR guided biopsy?
Yeah, so let's start with mammogram, right? Because
Yeah.
it's the most common thing people are going to come in the door with. So mammogram can show a nodule, which is like a small mass, or it could show white dots.
Mhm.
And the white dots are called calcifications. Now, the white dots are not nodules, okay? For all the world, I can't see that in the operating room. It's microscopic. So think about it. That's mind-blowing. The mammogram can see something microscopic,
Mhm.
right? So calcifications are calcium. It's the same bone, essentially. But what happens is those white dots can lay down in the milk pipes because the tissue can be transitioning into something abnormal or even an early breast cancer. If a patient only has those small white dots, an ultrasound ain't going to see anything. The mammogram's the only thing that can see it. So therefore, you have to do what's called a stereotactic biopsy. That's a fancy name for just saying you're using the mammogram to guide where the needle goes to sample the tissue.
Mhm.
Okay, so those people, if they got the white dots, they need the mammogram to guide the needle. Now, if somebody has a nodule on mammogram, usually, not always, but usually that nodule can be seen on ultrasound. So that's the sound waves. So if the ultrasound can see it, that's the easiest way for the radiologist to do a biopsy, because they hold the ultrasound probe and they numb you up and then they put the needle in and they can see it in real time, because ultrasound's showing you second-to-second images. Now, sometimes neither mammogram or ultrasound can see it, but the MRI does. Okay, so once again, if the MRI is the only thing seeing it, then you need to use that modality to do the biopsy. So an MRI, you got to lay in a tube on your stomach, your boobs go through the hoops, and then they put this grid against your breast. It's like a tic-tac-toe grid, but we're not doing tic-tac-toe. So they take one piece of the grid, and that's where the cancer is and trajectory, and they numb you up, and they put the needle through that tic-tac-toe part until they hit the cancer. They're taking pictures while they're doing it. So remember, you got a hot spot, right? So then when the hot spot's gone, that means the needle sampled it, took it away. So that's how they prove it with the MRI.
And are all those needles the same? Like
they're different. So they're different sizes, they're different lengths. It all depends on where the lesion is and how they got to get to it. Yeah.
I see. I see. And who are the folks doing these biopsies?
Well, it depends on where you are in the country and in the world. So I would say the large majority of the time, the person doing the biopsy with a needle is not the surgeon. Patients come into my office all the time. They're like, okay, doc, I'm ready to put the needle in. I'm like, oh, no.
No, you don't want that.
I'm going to talk to you about what we're going to do after that.
Yeah.
Okay, but so the radiologist does this. So a lot of people don't know there are radiologists specifically trained in breast care. So like they do those needle biopsies all day long. They are professionals. They are perfected at doing that. But there are some surgeons who have trained how to do that. And if you're in an access area where maybe there's not as many doctors around, then those surgeons may be the ones who do the needle biopsy. And as long as they've had good training and do a lot of it, it's fine. It doesn't matter who does it. They just need to be qualified and know what they're doing. Yeah.
Yeah. And then most commonly, those results take like 3 to 5 days to come back.
On average, so every place is different.
Yeah.
Okay, but I would ballpark it could come back as quick as 24 hours, 2 days. It can sometimes take as long as a week, especially if it's just a difficult thing for the pathologist to look at and make a call on what it is. Somewhere between there.
Yeah. So I think like that's the most anxiety inducing time for people is waiting on that result once they get the biopsy result back.
Everything, and I completely understand why, because your head-to-space goes to the worst case scenario. That's tough. So they do try to expedite. It's just, you also don't want the pathologist to rush. They got a lot of different things they got to do to even look at the tissue to figure out what's going on. And that stuff has to take time.
Yeah.
Yeah.
And speaking of pathology, I know that there is different types of breast cancer. Can you don't have to go like super in depth on maybe each one, but can you talk about like the different types of breast cancer a little bit?
Yeah. So to start off, breast cancer can most often come from the milk pipe, which is called the duct. So that's how you feed a baby milk. You got a bunch of pipes in there that go to the nipple. So those are called ducts. So most often, 80% of the time, it's going to come from the inside lining of the duct, okay? But you got the duct getting the milk to the nipple, right? But the milk's got to come from somewhere. So each duct ends in like this cotton candy thing that attaches to it. It's like a cotton candy on top of a stick, okay? The stick's the duct, cotton candy is the milk-making unit, okay? We call each milk-making unit a lobe, just a fancy name for the milk maker, okay? The second most common type of breast cancer is the milk maker, so lobular cancer. Okay, so ductal, the pipe, the stick, is the most common, and then lobular, the cotton candy, is the second most common type, okay? One is not worse than the other. All it's saying is where the cancer started. Now, cancer can be stuck inside the stick, the pipe, and that's called in situ, okay? So inside. That's pretty much as early as we can find breast cancer. Okay, we call that stage 0. But then what can happen is the cancer can start inside the stick, but then it learns how to bust out of it. Okay, so once it starts busting out, we call that invasive ductal cancer. Now with the cotton candy thing, the lobe, it can do the same thing. It can start inside the cotton candy thing, but then it busts out of the cotton candy, so then we say it's invasive lobular cancer. I don't know.
Really?
I picture food a lot.
Yeah.
I love this explanation.
That makes total sense.
So,
I can visualize it in my head too.
But like it gets even more like precise than that, right? Because we're talking about a stick and a cotton candy. Like we got to know, is the thing fast growing? What's feeding it? What's not? Because the goal is cure. It's not like where did it bust out of? It's like, how do we take care of it?
Yeah.
And what do we need to do? And what can we get away not doing to make sure we got it cured? So there's also like different things that feed breast cancer. So the most common thing is female hormones, estrogen and progesterone. And we can even see these in women who have stopped having their periods, like they've gone through menopause. And they'll ask me all the time, how in the heck is my cancer fed by hormones when I went through menopause at 50, I'm 60 now, I'm not taking any hormones. Where in the heck would those things come from? And what most people don't know is even after menopause, they're making hormone all the time until they die. And that's from the fat. Fat makes estrogen.
Mm-hmm.
So even after menopause, you're making estrogen.
Mm-hmm.
Now, there's another kind of breast cancer called triple negative. So to put that in perspective, when we look at breast cancer, we look at 3 things. So the first 2 things are your hormones. One's called estrogen, one's called progesterone. And then the third thing we look at is something called HER2 receptor. All that means is we take a cancer cell and we're looking to see if there's an antenna poking out of it called HER2. If you got the antenna, we got no bags, we got to treat it with medicine.
Mm-hmm.
So that's why there's 3 things we look at. For triple negative breast cancer, it doesn't have any of that. It's not fed by hormones. It doesn't have that HER2 antenna poking out of it.
Mm-hmm.
Okay.
It's just growing on its own.
Just growing on its own. We don't know why. We don't have
Yeah.
the technology to know yet.
Mm-hmm.
Interesting.
And then the final one is called HER2 positive. So I talked about that HER2 antenna. These cancers have the antenna poking out of it. And we got to know about that because we got to block the antenna and kill it.
Mm-hmm.
Mm-hmm.
Yeah.
Interesting. Now, is surgery recommended for all breast cancer? Is that typically part of every plan?
So it depends on the stage of breast cancer that the patient shows up with. Okay. So there's different stages. I'm going to go to the highest one right now. Stage 4 is when the breast cancer has gone out of the breast and it's circulated the body and it's gotten stuck in other organs. Okay. So it's gotten stuck in the bone, the liver, or the brain. Okay. If it's already circulated and it's sort of popping out on different parts of the body, sometimes surgery is not what we do.
Mm-hmm.
Okay. Sometimes we're going to give medicine to really keep that stuff shrinking and try to keep it as bay as long as possible, because just cutting a bunch of stuff off isn't going to help. Okay.
Mm-hmm.
Above stage 4, so there's stage 1, 2, and 3, surgery is going to be part of the plan to get the thing cured. Okay.
Mm-hmm.
We got to get some stuff out of there.
Mm-hmm. And then among surgery too, like, and kind of maybe that post-op period,
Mm-hmm.
Can you touch a little bit on maybe what most commonly you see your breast cancer patients go through too after surgery?
So it depends on the type of surgery,
Yeah.
right? So with surgery, it can be as simple, quote unquote, as getting the cancer lump out of there. Okay, so we call that lumpectomy, and you want to get that out. Just make sure the edges are clear. Sometimes we got to pop some lymph nodes out of the armpit area just to make sure they don't have cancer in them, or if they do have cancer in them, we got to pop them out of there. And then we have mastectomy, right? Where you got to remove the whole breast.
Mm-hmm.
So when you remove the whole breast, there's different ways to do that. Some people you can keep the nipple. Some people you got to take the nipple. So if you think about it, those have different recoveries, right? So if you take a smaller lump out, those people tend to be moving right after surgery. They go home the same day. They're going to be sore. They
Mhm.
had surgery. They're going to lay down scar tissue. The initial soreness will be for about the first 2 weeks, but when they get, which we'll get to in a minute, they get x-rays, which is radiation, the nerves go to sleep. And they tend to go to sleep for 3 to 6 months. Then after that, they wake back up and it scares the heck out of the patient because it starts hurting again.
Mm-hmm.
But that's natural. The nerves are waking back up. They're trying to finish the healing process.
Yeah.
A lot of people don't know when you do surgery, 99% of the scar matures within the first several weeks, first 8 weeks. But total scar healing takes 2 years. A lot of people don't know it takes that
Yeah, it's a
long.
long
So they're
time.
going to have aches and pains off and on for about 2 years.
Yeah.
Yeah.
Mm-hmm.
Yeah, I do. I think that's what a lot of people don't realize, and what may
Yeah.
come with that too, like maybe needing physical therapy or needing to
Yes.
rehab and stretch and
Yep.
exercise.
One of the biggest things people don't do, and we don't do anyway when we go to the gym, especially as we get older, is we don't
Yeah.
stretch.
Yeah.
Okay. And over time, if you're not stretching, especially if you're lifting weights, working out, your body tightens up. You can't do positions you could do 5 years ago. Getting on the
Exactly.
floor and getting off the floor becomes hard.
Yeah.
So think about surgery where we're impacting somebody very quickly.
Mm-hmm.
They may like hold their shoulder against their body just as a defensive mechanism after surgery because it feels better.
Yeah.
But because they're not moving, the shoulder gets frozen. And a frozen shoulder is no joke, man. That could take a
Mhm.
year,
No.
you know?
Yeah.
So motion's lotion is what I tell all my patients. You got to move. Got to
Yeah.
move the body, got to move the muscles.
Yeah. Especially
Yeah.
those mastectomies, that chest wall muscle really tightens up on them.
Absolutely. They got to move. They got to
Yeah.
stretch it. And not only that, we just talked about 2 years.
Yeah.
You have to stretch off and on for 2 years, and they don't know that. A lot of people are
Mm-mm.
like, I feel good 3 days after surgery. I'm Dunsky. I'm not going to do anything else. And I'm like, no. This is a roller coaster ride
Yeah.
It
for
really
years.
is.
So when
Yeah.
the roller coaster ride gets tough, you got to stretch. When it gets
Mhm.
easy, okay, you can skate.
Mhm.
Yeah.
That's a good way to put it.
Mhm.
That is a good way. Yeah, I'm going to steal that.
No, I'm going to steal a lot of things that you said.
Very helpful.
What are you seeing like mortality rates with breast cancer nowadays?
So one thing that I think is great is the mortality from breast cancer has decreased by, depending on what study you look at, about 43 to 45% from 1989 through the 2000s. Now, that's due to a couple things. It's going to be due to women doing more screening mammograms, right? So now it's accepted. Everybody knows they got to go get it, whether it's every year, every 2 years. Like they know they got to go do it. They don't really have an excuse.
Yeah.
The second thing is treatment. Okay. You got to cure cancer when it comes. So the treatments have come such a long ways in terms of being like laser beams or like heat-seeking missiles to really kill that cancer no matter where it is. That, I think, has been the biggest innovation that has really driven survival for breast cancer.
That's amazing.
Mm-hmm.
Do you feel like women are doing self-exams pretty regularly when you ask them? Or I guess, what are you telling them to do, or what should they be looking for when they are doing self-breast exams?
I would say most aren't. I would say the women who do self-breast exams maybe have a family history of breast cancer or something that prompted them to even want to do it. I would say most don't. I think it would be helpful if they do, because sometimes mammogram, as I said, it's 80% good, but there's 20% we don't find. They may find it, and then they bring it to our attention. So what I tell women is once a month, we don't gotta go crazy, once a month, and pretty much as soon as your period stops, okay, the day after it stops, do your breast exam because your hormones are at the lowest and the estrogen hasn't built up yet, so stuff's not swollen and inflamed. Just feel around there. You know what I mean? And basically by that, I mean, you're sort of going to go, you can either go up and down in stripes or you can do little circles, but you want to go from where your breast meets your belly over to your breastbone, all the way up to your clavicle, and then way over deep into your armpit area. And you first start superficial, like light touch, but then you got to go deep. So you got to give some pressure to that, you know, so you can feel the deeper tissues. But that's what I would tell them to do. And then look at the skin. I mean, you're in the mirror drying off anyway, getting ready to dry your hair. Just look, make sure there's no weird dents. Make sure all of a sudden the nipple's not puckering in all weird and stuff like that. Even skin lesions. Like if you see a mole that looks weird, you don't got to go breast. I mean, got to get a dermatologist. Melanoma happens anywhere, even on the breast. So just once a month.
Yeah.
You know? Yeah.
How often should they have a clinical breast exam, like a provider doing a breast exam for them?
So for women age 40 and above, or if they have a strong family history, it'd be earlier, but I would say once a year, at least, they want to come in to get a clinical breast exam. Even if their mammograms are good, once again, just looking at the skin, just make sure there's no weird dents going on and things like that. We have caught breast cancers that mammogram couldn't see.
Yeah.
So, yeah.
What would you say is your biggest recommendation for decreasing risk of breast cancer? I know we talk about this a lot and you're very passionate about it. So I want you to tell the world how you feel.
That's a loaded one. So the first thing in terms of breast cancer is, so I got a couple. Okay. It's not just one. Yeah. Okay. But if there was one I could choose right now, it would be what you're eating and what you're drinking. Okay, we'll come to hormones in a minute. But actually, I think what you're eating and what you're drinking is more important. And not only that, I talk to patients about this, and I don't think they think, and I keep trying to mention someone I remember, is their children. I'm like, so breast cancer is increasing in incidence across the world. So it's going up in the less than 50-year-old age group by 1.5% per year. Now, you might be like, who cares? It's every year. It's going up by 1.5%. In Asian Pacific women, it's going up by 2.5% per year. That group was never, they were supposed to be the lowest group. They are flying now. And, we're just seeing people younger and younger getting breast cancer now. Colon cancer, same thing. Yeah. So if there's one thing I think that really does need to pivot and change rapidly, and I think the public needs to do a grassroots movement and just really advocate for this, is what you're putting in your mouth and what you're drinking. Europe has already done a lot of this. We are way behind the times on this, but we got to do it even for the kids, man. Yeah. Okay. So what do I mean by that? So everybody knows Flint, Michigan, the debacle of the water that happened there. It's not that long ago. Indiana's water is terrible. Okay. We're not that far off Flint, Michigan. What do we do every day? We drink water, we cook with water, we bathe with water, we swallow the water probably while we're bathing or showering with it. Our kids, we'll give them juice, it has water in it. Yeah. So we have a ton of water going in. So over time, like things like forever carbons and things like that are going to deposit in your body, and that crap doesn't go away. The other thing is, like fruits and vegetables, people talk about like, I'm going to eat salad. I'm eating super healthy. How in the heck did I get cancer? And I'm like, well, were there pesticides on the stuff? Pesticides is poison. It kills insects. It kills mice. It will kill humans if we have enough of it in our body.
Mhm.
Yeah.
So trying to go organic as much as you can, and I'm not endorsing Whole Foods here. I don't care. Grow it yourself. It doesn't matter. But don't put, like Miracle Grow on it.
Right.
And just, try to buy organic as much as you can. Even the meat. The meat has a lot of hormones in it. We do think that may be changing the hormonal balances in children. We are now seeing a lot of kids getting breast development and periods much younger than typically we would see for average ages.
Yeah.
Mhm.
There's even some interesting articles out of Nature magazine on pesticides in the grass. Like you don't really see dandelions anymore. So people are putting crap all over the grass.
Yeah, you're right.
So they're saying from young children on, if they're barefoot in the grass, that's actually, I can't remember the fancy word for precancer, but it's changing their whole hormonal pathways. And that accumulates over time, that those pathways are already imbalanced. And that can affect things like microbiome in the gut. I think it's a cascade effect. And then they're more prone to cancer at a younger age, whether it's colon cancer, breast cancer. I mean, you take your pick. But they're now saying that it's at very young ages just due to environmental effects touching skin.
That is so wild.
Yeah.
How do you control that
Wow.
though? Like I feel like that's like a mass world
People
reverberation.
have to change culture.
Yeah.
Is what it's going to come down to. Dandelions are pretty, man. You can eat them for food. Okay. If the zombie apocalypse comes tomorrow, you can eat dandelions. Okay. So, I think we need to change culture. The yard doesn't have to be, monstrous green. The corn doesn't have to be 50 million feet tall in 2 weeks when it was never meant to be that. The apples don't need me to be the size of my fist.
Yeah.
Yeah.
Nothing was ever meant to be that way.
It's true.
Like your kids. I mean, if the grass is being sprayed, I wouldn't have their little bare feet on that. They're going to have shoes and socks on.
Yeah.
All the time, kind of deal. And once again, I think we need to really change regulations on pesticides and what is being sprayed on the food, what we're cooking with, utensils that we are cooking with. I think major changes have to happen. And I'm just very afraid that people are complacent and they won't.
Yeah.
Definitely. Industry and money and pushing it.
And I can't figure out why people don't, especially with kids.
Yeah.
You know what I mean? Like, we got cancer rising in kids.
Yeah.
We have younger people getting breast cancer is bad, okay? Because they are younger age group. They're going to have kids. And, God forbid that mother dies. You just took a whole family member out of the unit.
Mhm.
You know what I mean? Of a child who's trying to develop and grow now to a single parent, or if the father, unfortunately, is not there, no parents.
Right.
You affect so much in terms of the whole network of human social design.
Mm-hmm. Yeah.
It's compounding.
Even just the devastation of a mother going through breast cancer treatment in the family, even if they do well, it's still, it's a traumatic event
for everybody.
So
even the children
absolutely.
Young.
I feel like in Indiana too, like we're a very rural state, and so we're a big farming state.
Yep.
And I mean, a lot of, obviously the Midwest is. And so like,
that's all going in the water.
Yeah, and the water.
Even wells. People I have well water. I'm like, are you by farm?
Yeah.
It's going in the well water.
Exactly.
So I think we really need to address the water and the standards where we test the water. I think they're at the lowest bar. So, we won't die tomorrow. You know what I mean? But enough of it, can accumulate and cause issues.
Do you recommend people, if they can, like get like a specific type of filter in their house?
So if they're what I would love for them to get for civilian use is reverse osmosis systems. They're not cheap. I mean, I get that. But in terms of just the best thing that is available on the common market, that's what I would go for. If you can't, get a Brita. I don't even care. You know what I mean?
Just something.
So we have a lot of things too. Like my brother's wife will say, well, I drink Fiji water but I'm like, it's in plastic.
Yeah.
So what happens when you put plastic in the sun? It goes into the water. You're drinking plastic. And also it's great. It's from Fiji. That sounds great. But I don't know if they're dumping garbage in the ocean. You know what I mean?
Right.
It doesn't matter if it came from somewhere exotic. I don't know what's contaminating that water. So that doesn't make it better.
Could just be a marketing ploy. Like they just put a
label
on it.
Like,
exactly.
It looks super cute to drink.
It's probably actually from the tap.
Yeah, it could be. You know what I mean?
So,
but here's the thing. Maybe filtered water you buy at Meijer might be cleaner than the Fiji water that you're getting.
Yeah.
You actually don't know. People don't know what the quality of the water is, no matter what it is. That's terrifying.
It is. Makes you want to like take your own like test test
but
kit
once
with
again,
you to drink
the
any
tests
water.
are the bare minimum.
I know.
So it's also, but it's better than nothing. Don't get me wrong. So I don't know, there was a movie Erin Brockovich. I don't know if you're, where the industry was, basically contaminating the land and the water. People were getting childhood cancers. They were getting sick.
Oh.
She figured out it was that.
Yeah.
So that's going to be coming. It's not going to be right.
Yeah.
So, I don't know. But that's number one.
Yeah.
Okay. Number two is hormones. Okay. Hormones is a huge topic.
Very much.
I mean, there's just so much more we need to learn about hormones that we don't even know. But the thing is, what a lot of people don't know or don't like to envision is the hormones are supposed to go down during time. Okay. I mean, there's been millennia of human development. It was for a reason. The body just didn't decide one day to chuck hormones at age 50. There had to be a reason behind it, right? So the hormones are meant to go down over time. So, I totally understand when there's a need for hormones based on actual physical symptoms. But the amount of women who come into my office where they are on hormone therapy, especially after menopause, and they don't know why, hormones after menopause are medicine. I don't care if it's bioidentical. It's sexy, sounds great, it doesn't matter. It's still a medicine. So you have to know why you're on the medicine, because hormones after menopause, especially once you start tipping the line of age 55, definitely 60, will increase the risk of breast cancer development. And I know a lot of people will debate that, but it's been studied. It will increase risk. So you have to have a reason why you want to have an increased risk. There better be something happening for you to want to have that risk. A lot of people have no clue.
Yeah. That's shocking.
Yeah.
Or it's not told to them or managed maybe correctly, or maybe they're put on a medication by somebody, and maybe it was their OBGYN who was watching them at first, and then maybe that doctor retired, and then maybe their care got transferred to a primary care doctor, and they've just continued it. And I've seen that before with people.
I think it goes both ways of the street.
Yeah.
I think sometimes the doctors may forget or just not realize they're supposed to taper it down. Patients that don't want to taper down, but they don't understand the risk of breast cancer development. So I think it's both sides of the street on that one.
Yeah. And a lot of fear of coming off of it. I find like a lot of women are like, well, what if I have hot flashes? What if I can't sleep anymore? Like all of these things. It's like, well, you don't know until
number one, you don't know. Number two, medical innovation, right?
Yeah.
So there's medication called Veoza now that can help with hot flashes. There's other things, CBD, that can help. So you also need to ask the question, is there something non-hormonal that can do just the same justice?
Yeah, absolutely.
It's not one or done.
Yeah.
Exactly.
Yeah.
And hopefully too, those symptoms will improve over time.
Yeah.
Usually.
Absolutely. And as I said, with these other therapeutics that aren't hormones, maybe you can improve immediately.
Yeah.
So yeah.
Absolutely.
Yeah.
Okay.
Is there any other things you recommend for risk reduction or anything else you want to add?
The normal stuff, like in terms of risk reduction, just trying to maintain a good weight, fat to muscle ratio, those kinds of things.
Yeah.
It's the basics, man. There's Ockman's razor. It's simple, stupid is the answer. Do you know what I mean? We don't got to get fancy with it.
Exactly.
Yeah.
I feel like there's a lot of stuff out there now that's like, oh, this is going to cure this, or this is going to make you so thin, or it's
like take these amino acids, you're going to drop 10 pounds. You know what I mean?
No way.
Yeah, it doesn't work that way. Unfortunately, it takes work usually to see that benefit. And then you can go into the weight loss medications. We're going to have to just see how time plays out with those in terms of, did those truly help with the overwhelming cardiovascular disease and other things, diabetes. Yeah. And maybe we will find on the side of history that, yes, they did, just because obesity is such a big pandemic right now.
Yeah.
The risk is worth the benefit, or it's a smaller risk or something.
It might be. You know what I mean? We're just going to have to see how it plays out. Time will eventually tell the tale on that one.
Yeah. I think same thing with the hormones, like making sure it's managed well, making sure you've got a good provider following you.
Hormones. I'm not dogmatic where it's all or none. I think it just has to be judiciously and intelligently utilized, and then knowing when to start and when to stop.
Yeah.
And I think that research is coming. I feel like there's a lot more attention on menopause in general and hormones and what hormones actually do to our body. And so I'm anxiously awaiting that.
Well, I think menopause in a way is what breast cancer used to be. So remember breast cancer when we talked about it. Menopause, you suffered through it. You didn't talk about it. Now it's, you look on Instagram, TikTok,
everywhere.
Everybody's talking about it. So that's the first step to innovation, is you talk about it. then you get the movement to fix it.
Mhm.
So I think there's going to be a
Definitely.
lot more coming down the pike on that one.
I think so too.
Yeah.
Yeah.
I'm excited.
It'll be interesting to see.
Yeah.
Maybe we'll have a menopause
right? Stay
guru
tuned.
guest on here.
Yeah, yep.
Aw.
Well, Dr. Giblin, do you have any final thoughts or anything that you really want to, go out on?
I can't think of anything. Sorry, I'm gonna bore you.
Mammogram.
Yeah, get your mammogram. Yeah.
No,
What anything exciting to say? Shoot.
Yeah. That's okay.
Yeah.
The good thing is that the treatment for breast cancer continues to improve.
Yeah, and therefore women shouldn't be afraid to go get their mammogram.
Yeah.
Okay, so a lot of women don't want to take the time, or they're afraid of what it will find.
Mm-hmm.
It's going to be there anyway. So
Right.
you know what I mean? So you might as well try to find it early.
Mhm.
Yeah, absolutely. Well, thank you so much for joining us today and spreading your wisdom.
Oh, thank you.
We loved
Appreciate
having you
it.
here.
Yes, gonna absolutely steal some things from you.
And maybe have you on again sometime again in the future.
Sounds good.
Absolutely. Thank you.
Thanks.
Thank
The information that you hear on this podcast is not a substitute for medical advice. As always, please seek out personal care and advice from your medical team.